Okay, let's unpack this. Imagine you're sitting in the doctor's office discussing what's next for your treatment. You probably have some strong feelings, right? Maybe you really prefer taking a pill over getting an injection, or you prioritize a treatment that has fewer side effects, even if it means a slightly higher cost. We all have these personal leanings. But here's the big question. How much do those personal preferences actually influence your health outcomes? Does truly matching what you want with what your doctor recommends really make a tangible difference in how well you do?
That's exactly the fascinating question at the heart of our deep dive today. We're looking at a study protocol by Umar et al. From 2012. Now, a protocol, just to be clear, means it's a detailed plan for a study, laying out the rigorous methodology they designed, and it was designed specifically to measure the alignment or concordance, as they call it, between your treatment preferences as a patient and your physician's actual recommendations.
Okay, so not the results themselves, but how they plan to find the results.
Precisely. The core mission here wasn't reporting findings, but building the pathway to understand if this preference matching, as we'll call it, could genuinely lead to better health, greater satisfaction, and an improved quality of life for you. And it's important. This isn't just about one specific disease. It's really about refining the very essence of patient-centered care.
Right. The background here feels crucial. This idea of patient-centered care sounds inherently good, doesn't it?
It does, and it's formally defined as being respectful of and responsive to individual patient preferences, needs, and values.
So making sure your values actually guide the clinical decisions.
Exactly. And for good reason, because this whole approach has been consistently linked to some seriously positive outcomes. Things like improved patient satisfaction, a better overall quality of life, and even better adherence to your prescribed treatment plans. It really aims to place your individual needs right at the forefront of healthcare decisions.
It makes intuitive sense.
It does. At its heart, the idea is simple. Knowledge only truly helps when we understand it and, crucially, use it. However, the existing evidence for the value of truly matching these preferences was, well, somewhat limited by how preferences were measured in earlier studies.
How so? What was the issue?
Well, many studies used a very simplistic approach, like yes-no questions, or just choosing between option A and option B.
Ah, okay. Very black and white.
Right. And this binary method, while easy to administer, often failed to capture the strength of your preference. Or, the complex trade-offs you might make in a real-world scenario when different aspects of treatment have different levels of appeal or concern for you.
That makes complete sense. I mean, you can't just ask if someone prefers a pill or an injection without the full context, like how often you take it or what the potential side effects are, right?
Exactly. Context is everything. Another issue is that many previous studies relied on hypothetical scenarios. They'd ask patients what they would prefer in some theoretical situation.
But real life isn't hypothetical.
Precisely. These approaches didn't fully reflect the actual choices and compromises patients face when they're sitting there, discussing real treatment options with their doctors. So this raised a really important question. How do we truly capture the nuance of your preferences, with all their complexities and trade-offs, to see if matching them really impacts your health outcomes in a meaningful, measurable way? This study aimed to bridge that gap by building a more robust framework.
Okay, so how did they actually go about planning to measure this elusive idea of preference matching?
Well, the study itself was set up at the University Medical Center Mannheim in Germany, and they chose to focus on patients with moderate to severe psoriasis.
Psoriasis. Why that condition specifically?
It's a chronic skin condition, which means it requires ongoing management and treatment decisions over time. That makes it an excellent model for exploring these long-term choices where patient preferences can really come into play significantly. And they developed a novel metric, something new, called the Preference Matching Index, or PMI.
PMI.
Let's walk through how they plan to build this PMI. It was essentially in 3 distinct steps.
Okay.
The first step was all about capturing your preferences, making sure the patient's voice was heard clearly and, importantly, comprehensively. So instead of those simple A versus B choices we talked about, they used something called choice-based conjoint analysis, or CBC.
CBC sounds technical. What is it in simple terms?
Think of it like a very sophisticated, carefully designed survey, but one that actually mimics how you make decisions every day. You're presented with multiple options, each with different pros and cons, different features, and you have to pick what's best for you. It forces you to make trade-offs just like you do in real life.
Ah, okay. So it's more realistic than just yes or no.
Much more. To do this, the study first identified various attributes of psoriasis treatments, like different features and their different levels or variations. These fell into two main categories. First, what they call process attributes.
Process attributes.
Yeah.
Like how the treatment happens.
Exactly. It's all about how you receive the treatment. This included things like how long the treatment session takes, say, 5 minutes versus 2 hours, how often you need it, maybe once every 3 months versus twice daily, the cost, obviously nothing versus maybe €200 a month, where you get it at home versus in a clinic, and even the method of delivery, like a skin cream versus injections, all the practical stuff.
All right, the logistics. And the second category.
The second was outcome attributes. This focuses on what you actually experience from the treatment itself. So this meant looking at things like how much the treatment improves your condition, like a 25% reduction in plaques versus maybe a 100% reduction, how long those good effects last 2 weeks versus maybe a whole year, the probability of side effects, a 1% chance versus a 100% chance, also the probability of the beneficial effect actually happening, and the reversibility or severity of any side effects.
Wow, that's a lot of factors to weigh up.
It is. And you, as the patient in the study, would be presented with 12 pairs of different treatment scenarios, combining these attributes in various ways. This forced you to make those real trade-offs between different aspects. Which is more important to you, less chance of side effects or a quicker result? This whole elaborate process allowed the researchers to generate specific preference scores for every single attribute level. These scores accurately indicated how much you truly valued each one. A higher score literally meant a greater preference for that specific feature.
So essentially, it's creating a kind of personal fingerprint of what truly matters to you in a treatment, a detailed map.
Exactly, a unique map of your values, much richer than just a simple choice. Okay, so once they had that detailed map of your preferences, the second step was pretty straightforward, understanding the doctor's actual recommendation.
How'd they get that? Just ask
Yeah.
the doctor.
Even simpler. The research team just took the actual treatment prescribed or recommended by the physicians directly from your medical records after your appointment. No interpretations, no asking why, just the objective fact of what was put into action or advised.
Okay, so step 1 is the patient's detailed preference map. Step 2 is the doctor's actual recommendation. What's step 3?
Step 3 was bringing these two pieces together to calculate the PMI, the actual match score itself. This is where the study's real innovation lies. They compared your individual preference goals, derived from that sophisticated conjoint analysis, to the attributes of the specific treatment your physician actually recommended.
How did they compare them, like numerically?
Yes, exactly. They created a personal scale just for you. It ranged from your absolute least preferred possible treatment combination based on your scores, which was assigned a value of 0, all the way up to your theoretical most preferred treatment combination, which got a score of 1. The PMI then took the physician's recommended treatment, looked at its attributes and your scores for those attributes, and plotted that treatment onto your personal 0 to 1 scale.
Ah, I see. So if the doctor's choice aligned perfectly with your top preferences, you'd get a score close to 1.
Precisely.
And if it was really far off from what your scores indicated you wanted, you'd be closer to 0.
That's it. It provides a precise numerical measure of how well that specific recommendation fit your ideal treatment profile, based on the trade-offs you made earlier. This highly quantitative approach allowed for a much more objective measure of that patient-physician alignment, moving beyond just, subjective feelings or guesses about whether you like the plan.
Okay, that PMI metric sounds pretty robust. So with this innovative index established, what do they plan to do with it? How would they see if it mattered?
Right, so the plan was then to follow the participants over a 24-week period. And during that time, they'd assess 3 key outcomes to see the real-world impact of this preference alignment, this PMI score.
What were the outcomes?
First, they looked at the clinical outcome. This was measured using the Psoriasis Area and Severity Index, or PASI score.
PSI score? Is that standard?
Yes, it's an objective, widely used measure in dermatology. It ranges from 0, meaning no disease, all the way up to 72 for maximal disease severity. A score 10 or more generally signifies moderate to severe psoriasis. Here, they hypothesized a very clear link. The better the match between your preferences and the treatment, meaning a higher PMI score, the more they expected to see your actual disease severity reduce over those 24 weeks.
So a higher PMI should correlate with a bigger drop in the PSI score.
Exactly, a negative association between PMI and the change in PSI. And when they talk about looking for a statistically significant link, they mean they were designing the study to be powerful enough to detect a strong, reliable connection, one that wasn't just due to random chance or coincidence.
Makes sense. What else did they measure besides the clinical side?
They also looked at patient-reported outcomes, things reflecting your experience. One of these was your treatment satisfaction questionnaire for medication, or TSQM.
Okay, that sounds straightforward. How happy were you with the treatment?
Pretty much. It directly measured your satisfaction levels. And for the TSQM, they predicted, logically, that a better preference match, a higher PMI, would lead to greater overall satisfaction with your treatment.
And the other patient-reported outcome.
That was the Dermatology Quality of Life Index, or DLQI. This is a specific questionnaire that assesses your health-related quality of life, particularly concerning how skin conditions impact you. Scores range from 0 to 30, where higher scores indicate greater impairment and thus a lower quality of life.
So for this one, they expected the opposite relationship.
Correct. For the DLQI, they hypothesized that a better match, higher PMI, would lead to less impairment, a lower score, or a greater reduction in the score, and therefore a better quality of life over the study period.
So bringing it back to the patient, what did all this rigorous measurement aim to achieve? Sounds like a lot of data collection.
It was designed to be thorough. The researchers were very careful. They purposefully planned to include a wide range of other factors in their analysis, too. Things like your age, sex, education level, household income, and even other existing health conditions you might have, like depression or psoriatic arthritis, which often occur alongside psoriasis.
Why include all of that?
By accounting for all these other variables, potential confounders, they're called. They aim to ensure that they could truly isolate the specific, measurable impact of the preference matching itself, to really see if the patient's voice, captured in this sophisticated way via the PMI, genuinely affects the tangible results of medical care, both clinical and subjective. This wasn't just about investigating if you felt better aligned. It was about scientifically testing if you actually get better when your preferences are better matched.
That's a critical distinction. So thinking bigger picture, what are the broader implications here?
Well, what's really fascinating is that this methodology, this whole PMI concept, using conjoint analysis, while they tested its design with psoriasis, it could potentially be applied much more widely.
To other chronic diseases, you mean?
Exactly. Think about conditions like diabetes, arthritis, heart disease, any situation involving long-term management and complex treatment choices. This careful approach offers a potentially powerful, validated tool. It could help precisely identify the specific treatment features that genuinely drive your preferences as a patient, whatever the condition, allowing healthcare providers to understand what truly matters to you across a much broader spectrum of healthcare.
And this is critical because, as the study protocol itself notes, there can often be a mismatch, right, between what doctors recommend and what patients actually prefer.
Yes, and that mismatch isn't just a minor inconvenience. It can lead to significant patient dissatisfaction, which sounds bad enough.
But it has knock-on effects.
Yeah. Crucially, yes, that dissatisfaction can directly affect how well you adhere to your recommended treatment. If you're not happy with the treatment plan, if it doesn't align well with your values or your lifestyle, well, you might not stick with it as diligently.
And that obviously leads to less optimal health outcomes, even if the treatment itself is potentially very effective.
Precisely, despite the best intentions of the physician and the potential efficacy of the drug or therapy.
Okay, but does acknowledging patient preferences, maybe using a tool like this, does it risk limiting a physician's options? Forcing them into choices they might not see as clinically best?
That's a really important question, and the study design actually anticipates this. It suggests that it's not necessarily about forcing a specific choice. You, as a patient, might actually have equal or maybe near equal preferences for several different treatment options, especially if those options share certain key attributes that you value equally.
Can you give an example?
Sure. Maybe for you, the most important things are taking the treatment at home and it being quick to administer. In that case, perhaps both a daily tablet and a twice-daily cream could score very similarly in your preference analysis, making them almost equally desirable to you on those specific points, even if they differ in other ways.
I see. So it's not always about one single perfect option.
Exactly. This insight actually gives significant room for a more meaningful shared decision-making process. The doctor can truly understand your underlying values, what drives your preferences, and potentially still have flexibility to recommend an effective treatment that you are also highly likely to embrace and adhere to. It fosters collaboration.
Okay. Now, you mentioned this was a study protocol. Did they acknowledge any potential limitations in their planned approach?
Oh, yes, absolutely. Good research practice always involves acknowledging limitations. They were upfront about a few things. For instance, they acknowledged that participants completing the conjoint analysis might report somewhat biased preferences. This could happen if someone has what they called a dominant preference for one particular attribute.
Like what?
Well, say you have an extreme aversion to needles. Your desire to avoid injections at all costs might overshadow all other considerations, potentially skewing your reported preferences for other attributes like efficacy or frequency.
Okay, that makes sense. What else?
Also, the study planned to infer adherence based on satisfaction, assuming that more satisfied patients are more likely to stick with treatments. They weren't planning to directly measure adherence itself, like counting pills or tracking usage.
So an assumption, albeit a reasonable one.
A reasonable assumption, but still an inference. And importantly, they also considered whether the very act of asking you about your preferences in such detail might itself influence how satisfied you later reported feeling, or even your quality of life.
Just the act of being asked makes you think differently.
Potentially, yes, it could introduce a bias. So, to guard against this, they took a really rigorous step in their design. They planned to collect all your preference data before your consultation with the physician. And critically, they would never share those individual preference results with you, the patient, or your doctor during the entire 24-week study period.
Wow, okay, so the measurement wouldn't influence the behavior they were trying to observe.
Exactly. That's a testament to their commitment to rigorous design, really trying to isolate the effect of preference matching and get the most unbiased results possible from the planned study.
This whole deep dive into the Umar et al. Study protocol really highlights the incredible meticulous work involved in truly understanding what makes healthcare genuinely patient-centered. It's clearly about moving way beyond just assumptions and good intentions, isn't it? Towards scientifically measuring the tangible impact of listening to and understanding you, the individual patient.
Absolutely. Ultimately, tailoring treatment recommendations to your individual preferences based on a real understanding of those preferences is such an essential part of high-quality care. And efforts like the one outlined in this protocol, aiming to implement preference-based tailoring, perhaps even into routine clinical care, eventually they have the potential to improve, well, almost everything, from the quality of the patient-physician interaction itself to treatment adherence, your satisfaction, and importantly, the actual clinical outcomes you achieve.
And it started with psoriasis, but the potential seems much broader.
For sure. This methodology, originating in psoriasis treatment planning, really offers a powerful blueprint. It's a way forward for advancing patient-centeredness across a whole wide array of chronic diseases, truly personalizing healthcare in a measurable way.
Ultimately, this deep dive leaves us with, I think, a pretty provocative thought. How might a deeper understanding of your own preferences, not just in medical decisions, maybe, but in all aspects of your life, how might that empower you to better advocate for what truly matters to your own well-being? And maybe make choices, big and small, that genuinely align with your core values. Something to think about